Today I'm discussing the gynae recall questions of INI-CET May 2023 session. So this we have prepared from the students who have given the exam. So I tried my best to compile the questions in the correct form, the way it has come in the exam with the all four options. Okay. So let us start with the first question. Vaginal discharge. A female presented with vaginal discharge. The pH was acidic. It is non-itchy, yellowish discoloration. Lactobacillus count is normal. And what is the diagnosis? I think in the question, because some of the students have sent me the question, they have written female is using the oral contraceptives. Okay. So I will discuss in both ways. Now, the options given to me are bacterial vaginosis, chlamydia, excessive normal discharge, or candida. Number one, we will try to rule out options one after the other. Okay. So first option given to me in this question is bacterial vaginosis. And bacterial vaginosis is a condition. So normal flora of the vagina, as all of you know, is Dorderlin bacillus, which grows with the estrogen content. So this bacillus is present in abundance in the reproductive years of life because it breaks down the glycogen content into lactic acid. So making the pH of vagina acidic that inhibits the growth of the pathogens. So bacterial vaginosis is the first situation given to me here. In bacterial vaginosis, the normal lactobacillus is replaced by Gardnerella vaginalis or Haemophilus or mycoplasma, and the pH changes to alkaline. So, and here there is a fishy odor or foul smelling vaginal discharge. So this option is ruled out because here the pH given in the question is acidic pH, okay, which rules out bacterial vaginosis because the pH in bacterial vaginosis is more than 4.5, that is towards alkaline. Number two, there is always a fishy odor or foul smelling discharge. Number three, whiff test is positive, so nothing is given in this question. So bacterial vaginosis is already ruled out. Now, one thing I want to tell you here is vaginitis, which is a cause of vaginal discharge. The main causative agents we talk about is trichomoniasis, candidiasis, and bacterial vaginosis. When we talk about cervicitis, there is gonorrhea infection and there is chlamydia infection. So they reside in the endocervix. Whenever the body resistance is reduced or there is any instrumentation, they can gain entry to the upper genital tract of the female and can lead to PID, pelvic inflammatory condition, which is mostly the PID causative agents are sexually transmitted, and when they gain access to uterus causes endometritis, to the fallopian tube salpingitis, and to the ovaries oophorytis. Okay. Number three is excessive normal discharge. Number four is candida. In candida, there is thick curdy white vaginal discharge. Number two, in candida, vaginal discharge is always present and itching is a very prominent symptom. So candida is also ruled out in this situation. So the answer is excessive normal discharge whenever due to any physiological condition the secretions from the endocervical glands is increased. That leads to non-itchy discharge and the pH of the vagina remains acidic. This condition can be called as leukorrhea, which is a physiological discharge. Okay, physiological discharge. Okay, the point in favor of this excessive normal discharge or leukorrhea is the pH is maintained acidic and the discharge is non-itchy and there is no foul smelling. Fine. So I hope it is clear to all of you. Now, in trichomoniasis, remember the most prominent symptom is itching and there is strawberry spots in vagina. There is greenish vaginal discharge. Causative agent is a protozoa, which is a flagellated microorganism, and drug of choice is metronidazole. Number 2, when it is candida, itching is present and there is thick curdy white vaginal discharge. Thick curdy white vaginal discharge. And the drug is antifungal, that is fluconazole. About bacterial vaginosis, I have told you that itching is absent, but there is a foul smelling vaginal discharge. Clue cells are positive on the saline microscopy, and in this case pH is more than 4.5. Whiff test is positive and Amsel's criteria is positive. Amsel's criteria is positive and it is not STD. The drug of choice is metronidazole. Fine. Now, next question in this list is a pregnant woman with a known history of fibroid uterus. So there is already a lady, she is already having fibroid and now she is pregnant. During pregnancy, she comes with acute pain abdomen, fever and increased leukocytosis. What is your probable diagnosis? So this is very, very clear and simple question. Even the final year MBBS student can answer this question because it is very, very clear-cut clinical history. Whenever there is a female with fibroid and she is pregnant, okay, and she comes with acute pain abdomen, plus there is history of fever, there is TLC count which is raised. So in this case, my first differential diagnosis will be red degeneration of fibroid. If suppose there is no history of fibroid given and the female is pregnant and she comes with an acute pain abdomen, we have to rule out the surgical emergencies as well. So if I talk about the gynae, then my first diagnosis in that case, when the history of fibroid is not given, I will think of an abruptio placentae because abruptio is more common than red degeneration. Okay. Second, I will make a diagnosis of red degeneration of fibroid. Third will be twisted ovarian cyst. And I have to rule out with a history and examination the possibility of acute appendicitis or there is any obstruction in the gut. So surgical emergency should also be ruled out. But this is a very, very clear-cut and straightforward question where a female is having fibroid, she is pregnant and she comes with an acute pain abdomen with leukocytosis, with fever. So my investigation of choice will be ultrasound. Now, why does the red degeneration of fibroid occurs? Red degeneration of fibroid occurs because of thrombosis in the veins, or there is aseptic necrosis. So always remember, there is another question which always they ask, what is the management of red degeneration of fibroid in pregnancy? So management, friends, is conservative management. No surgery, never we go for surgery. Why? Because we are not going to gain anything. We have to just admit the patient, take the consent, start the IV fluids. Always admit your patient, take the high-risk consent, start IV fluids, give analgesics. Your patient will be absolutely fine. This management is called as conservative management. So for acute red degeneration of fibroid, the management is conservative management, and there is no surgical management, nowhere the surgery is recommended. Okay. So in this case, the answer will be red degeneration, twisted or torsion of ovarian cyst. The history will be something different. Okay. And infection is again not the presentation like this, and not even the preterm labor pains, because we are not able to explain why the fibroid is leading to all these problems. So my diagnosis, if there is a clear-cut history with an investigation report is given, so I am going to make a diagnosis of red degeneration of fibroid. Okay. Had it been fibroid not given in the history, I would have thought of twisted ovarian cysts or appendicitis or other surgical emergencies. Okay, so remember two things: clear-cut history suggestive of red degeneration of fibroid. Number two, the management is a conservative management. Now, why we don't want to do surgery? Because we do not gain anything in this situation. And number two, when there is a pregnancy, the anatomy is very much distorted, and this uterus, it is a very, very vascular organ because it is receiving the blood supply from the uterine artery. At term pregnancy, the blood supply at the level or blood flow from the uterine artery is 750 ml per minute, which is a huge amount of blood flow. Plus, there is always an anastomosis from the ovarian artery. So it is very, very vascular organ. Fine. Now, next question is, a 26-year-old female came with a history of infertility for 6 years. BMI is 30 kilogram per meter square with an excessive facial hair growth. A young female with infertility and BMI is given, plus there is excessive facial hair growth. Fine. So this history gives me a clue towards polycystic ovarian syndrome, because polycystic ovarian syndrome, although the very common presentation, if it is an unmarried female, then the common presentation is the like menstrual disturbances in the form of oligomenorrhea or secondary amenorrhea or infertility. When there is a beginning of the PCOD, the cycles may be heavy cycles because there is high levels of estrogen, and the protective or the anti-estrogen like progesterone is like deficient. So most important cause of anovulation with menstrual disturbances and with increased androgen, that the presentation is hirsutism, where there is increased facial hair growth. Okay, then it is mostly PCOS, polycystic ovarian syndrome, provided the other causes of hirsutism you have ruled out. What are the other causes of hirsutism? Is congenital adrenal hyperplasia, that is late onset, congenital adrenal hyperplasia, late onset. Then there can be androgen producing or virilizing ovarian tumors. In virilizing ovarian tumors, there will be a feature of clitoromegaly. In cases of late onset of congenital adrenal hyperplasia, there is prepubertal hirsutism. Okay, prepubertal hirsutism. then there can be the adrenal tumor which is androgen producing. So that is what is the differential diagnosis of PCOS. So most common is PCOS, provided other causes of hirsutism you have ruled out, that is congenital adrenal hyperplasia, late onset virilizing ovarian tumors, and androgen producing adrenal tumors. Now in this question they are not asking much about the PCOS, they are asking about the management of such a case. Always remember, in the previous INI-CET exam, okay, the topics are the same, but the framing of question may be slightly different. So one thing important you have to remember in PCOS is a Rotterdam criteria. In the Rotterdam criteria, there is hyperandrogenism, that is increased androgens, that is clinical appearance. Clinical appearance is increase in the facial hair growth, there is acne, there is temporal balding. That is what is the presentation of anti-androgenous clinically, or there is a lab finding which is suggestive that androgen levels are high. Number two, there is an ovulation leading to menstrual disturbances like oligomenorrhea, hypomenorrhea, secondary amenorrhea, and later on there is infertility. Then there can be ultrasound finding which is showing polycystic ovaries. This is Rotterdam criteria. So when we talk about the management, just remember that in this case, there is estrogen which is high, there is androgen which is high, there is increase in the insulin resistance, and there is an ovulation, plus there is a progesterone deficiency. So remember this hormonal pathology in PCOS, there is a vicious cycle which is formed. So obesity is very important feature. In obesity, there is increased androgens, and remember, increased androgens, like always suppresses the ovarian function. So first step in management is always weight reduction in obese patient. And second line of management is that you introduce the drugs. So drugs is according to the symptoms. In this question, they have asked that what will be your management. So I will just read out the options: weight reduction, metformin, ovulation induction with clomiphene; weight reduction, metformin, ovulation induction with gonadotropins; finasteride, metformin, wait for spontaneous conception; finasteride, metformin, ovulation induction. Now, first of all, always select an option where there is weight reduction written, okay? Because that is what I said, it is a first step in managing a patient with PCOS who is towards the obesity side. So these two options we have ruled out, and always my first choice is not going to be anti-androgen drugs straight away, okay? So it is weight reduction. Now what to select? Am I going to select a clomiphene citrate, or am I going to select HMG, human menopausal gonadotropin? Of course, my first selection will be clomiphene citrate, although nowadays better drug than clomiphene citrate is letrozole, which is aromatase inhibitor, and there is less side effects, okay? But we can give clomiphene citrate as well, okay? So I am saying letrozole has been replacing clomiphene citrate, but in none of the options the letrozole is given. So my answer will be weight reduction. That is the first line management or first step in management. Then metformin, which will going to act or which will correct the insulin resistance, because insulin is stimulating Insulin is stimulating the theca cell hyperplasia in the ovary, and theca cells produce androgens, causing hirsutism and suppresses the ovarian function, leading to an ovulation. Okay, so my answer here will be weight reduction, metformin, which will keep a check on the insulin resistance and as well as the obesity levels. And because the patient wants treatment of infertility, so I am going to give ovulation induction with clomiphene citrate. Got it? Now, next is most common cause of menorrhagia in puberty. Always remember, when the female or a young girl is starting with menarche, the initial cycles are anovulatory. That means there is high levels of estrogen and lack of progesterone. Now, what is estrogen going to do? Estrogen is going to cause proliferation of the endometrium, and progesterone causes secretory changes. So after the levels, if there is no fertilization of the ovum, then the estrogen corpus luteum disintegrates, estrogen progesterone level falls, and normal menstruation is estrogen, progesterone, withdrawal, bleeding. And the endometrial thickness, when there is progesterone present in the body, the endometrial thickness is well controlled, and then shedding of the endometrium is in the controlled manner. But when there is puberty time, okay, or premenopausal time, in both the cases, in puberty time, the ovarian function is starting. In the premenopausal female, the ovarian function is ending. So there is a hormonal imbalance. In the reproductive time, the ratio between estrogen and progesterone is maintained. So the cycles are, most of the females is well controlled cycles. So most common cause of menorrhagia in puberty or in the pubertal girls is not endometriosis, and even the chances of malignancy is not very common. Bleeding disorder or a clotting factor deficiency is again not the most common presentation. So it is usually an ovulation, because hypothalamo pituitary ovary and uterine axis is getting mature. So initial cycles, I said, are anovulatory, where there is a thick endometrium, and once the shedding occurs, so it will be a heavy cycles, because there's a progesterone deficiency. So there is protective progesterone is absent in them. So, secretory changes, and the endometrial thickness is not being there, means it is not maintained. So there is a heavy cycles because of the shedding of the thick endometrium. Fine. Now, in a female, next question, presented to gynae OPD with complaints of vaginal discharge. Upon further investigation, clue cells were found in the microscopy. Okay. Now, what are these clue cells? Okay. Bacterial vaginosis, remember, the vaginal discharge topic, the PID, the NACO kit, this is very, very important. When I was taking a session for, a mock session for OBS gynae before the INI-CET, or after I have taken the recall sessions of NEET PG, there is so much of focus on the vaginal discharge, or on the NACO color code kits, or in the PID. Usually this is a very, very hot topic for questions. Okay. So what are the clue cells? Clue cells, is seen in bacterial vaginosis. And the causative agent, most common causative agent is Gardnerella vaginalis. Okay. So what are the clue cells? Clue cells are normal epithelial cells, and bacteria are adherent to them. Normal epithelial cells of the vagina, where bacteria get adherent. So that is what I have been explaining in my sessions. So let us see which option is matching to this. Okay. So can you see clue cells on saline microscopy? Yes. We can make a wet film. Okay. Now, so Gardnerella vaginalis rods are accumulated. Is that the clue cells? No. Macrophages have phagocytosed the Dodderlin bacilli. Is that the clue cells? No. So it is epithelial cells studded with bacteria. That is what is called as clue cells. So you can see this is a saline microscopy. This is an approximate figure to just make you understand. This is a normal epithelial cells, and can you see that this is a clue cell where the normal epithelial cell of vagina and it is studded with the bacteria. So exactly you see in saline microscopy the film like this. This is just to make you understand. So what is a clue cell? Fine. Now, which of the following is not the treatment of endometriosis? Well, I really doubt if it was a multiple options, because in INI-CET, there is more than one option. So endometriosis is the presence of endometrial tissue outside the uterine cavity. And most common site for endometriosis is ovary, where it presents as a chocolate cyst ovary. And the rare site for endometriosis is CNS or it is spleen, whichever option is given to you. So in endometriosis, the most common symptom of the female, it is mostly the reproductive age group female, and usually the most common symptom of the patient is pain. And what type of pain? It is congestive dysmenorrhea. Okay, congestive dysmenorrhea. Next is dyspareunia. When there is adhesions in the pouch of Douglas, the uterus mobility becomes restricted and there is a tenderness in the pouch of Douglas, so dyspareunia. And another important presentation is infertility. So this is a classical presentation of endometriosis. Pain is the most common symptom, and congestive dysmenorrhea, there can be a chronic pelvic pain, there is dyspareunia, and there is infertility. There can be menorrhagia, but menorrhagia is usually not the most common symptom. In endometriosis, usually patient presents in three forms. Three type of presentations is seen in endometriosis. Number one, if your patient has presented with symptoms like pain, or she has presented with infertility, or her common presentation can be adnexal masses. Like this is the uterus, this is the ovary, and there is bilateral chocolate cyst ovary. Okay, bilateral chocolate cyst ovary. Now, why there is infertility? Because there is lot of peritubal and periovarian adhesions, and uterus, ovary, fimbria are entangled in adhesions. So due to immobilization of fallopian tube leads to infertility. So fimbria get entangled, it is not able to pick up the ovum, and hence infertility. So endometriosis is hyperestrogen state, and usually it is seen in a high socioeconomic status female. Then those who are nulliparous, those who are having late marriages, okay, in all those females, they are at risk for endometriosis. One most important point you should remember is endometriosis is responsible for 40 to 50% cases of unexplained infertility. The cause you will find is endometriosis. So one of the important and the gold standard investigation in endometriosis, friends, is laparoscopy, because it is diagnostic as well as it is therapeutic. So three presentations of endometriosis, whether it is pain, dyspareunia, chronic pelvic pain, congestive dysmenorrhea, or there is infertility, or there can be bilateral adnexal masses. Okay. So laparoscopy remains the gold standard investigation. Now, in this question, they have asked which is not used in the treatment of endometriosis. Leuprolide, which is aromatase inhibitor, and it will be an action is anti-estrogen. So it is used, it can, is used to treat the endometriosis as such. That means you treat the symptom of endometriosis. Medroxyprogesterone acetate is again used in the treatment of endometriosis because it is going to treat the symptom of menorrhagia. Okay. And even OCPs can be given to treat the symptom of menorrhagia and to treat the symptom of dysmenorrhea because the cycles will become the anovulatory. So continuous manner you are giving either the progesterone or a progesterone releasing IUCD, that is Mirena, or you give OCPs. Okay, but mind it, they are not going to treat endometriosis, they are to treat the symptoms. The drug to treat endometriosis is GnRH analogs. And surgical management, you try doing the laparoscopic management. Estradiol and cabergoline has got no role. So if there was an option like A and B, I am going to mark A and B as my answer. Cabergoline is a drug of choice for anovulation due to hyperprolactinemia. Okay. And bromocriptine is a drug of choice for hyperprolactinemia with anovulation with infertility. So that is what you are supposed to remember. So here the answer, according to me, will become A and B both. Leuprolide and medroxyprogesterone acetate are given. Okay. Now next, SRY gene is located on. Always remember, whenever we are taking lecture, we have been telling the students that SRY gene is called as sex determining gene, and it is located in distal portion of short arm of Y chromosome. Distal portion of short arm of Y chromosome. Now, what is the importance of this sex determining gene? So it is located on short arm of Y chromosome, and it is responsible that it is going to be a male child. Male child with XY 46XY is going to be the genotype of this child. Again, this gene is responsible for transformation of undifferentiated gonad into testis. So karyotype will be 46XY. Okay. Undifferentiated gonad at 7th week of pregnancy into testis. Testis usually have the Sertoli cells and testis have Leydig cells. Leydig cells in the intrauterine life produces testosterone, which is responsible for external genitalia development in the males and internal genital organ development in the males from the Wolffian duct. And Sertoli cells secrete Mullerian inhibiting substance, which inhibits the development of Mullerian duct because males should not have uterus. So remember, SRY gene is located on the distal part of short arm of Y chromosome. This is sex determining gene, and there will be a normal male child with karyotype of 46XY. This gene is responsible for undifferentiated gonad at 7th week of intrauterine life to transform into testis, and the gonad in this child or the fetus is going to be the testis, which will contain Sertoli cells that secretes Mullerian inhibiting substance, which inhibits the development of Mullerian duct and will form remnants. And Leydig cells will secrete testosterone, which is responsible for external and internal genital organ formation in the male fetus. Okay. If there is any problem in the SRY gene, that will lead to a condition called as Swyer syndrome, which is pure gonadal dysgenesis. In that case, it is a baby with an testis undescended in the inguinal region with an external genitalia of the female, but internal genital organ says uterus, cervix, fallopian tube, and vagina. That is what is a Swyer syndrome. SWYER syndrome, which is pure gonadal dysgenesis. Okay. SWYER syndrome, which is defect in the SRY gene. So it is pure gonadal dysgenesis. In this case, the genotype is a boy, but phenotype. So it is a cause of male pseudo hermaphrodite. Okay. So here the external genitalia will be female. External genitalia will be female, but there is uterus, cervix, fallopian tube present, and there is undescended testis. So in this case, the treatment of this patient will be gonadectomy, because this undescended testis is the risk factor for testicular tumors, and you will give her estrogen progesterone so that there is a breast development that take place, and there is a treatment for primary amenorrhea. So this patients you get with at puberty presenting with primary amenorrhea, and there is no breast development, and these are a female looking patients. There is no breast development because estrogen is not there. But when you have diagnosed, okay, by the clinical examination, flat females, okay, then external genitalia female, then there is inguinal hernia, you get an ultrasound done, so there is undescended testis and there is uterus present. And confirmatory is always your karyotyping, so it is 46XY. Then you counsel the parents and you do gonadectomy after the puberty is attained, and you transform them into girls, because from the childhood they know that they have born as girls. So you give estrogen progesterone, which will cause feminism, which will cause here the development of the breast, and then you like once you stop, they will have menstruation, because uterus will start functioning if they will respond to the hormones. Now, complete gonadal dysgenesis, that is, I just said, because of the SRY gene mutation. Is it deletion, inversion, point mutation, or translocation? So usually it is point mutation. Okay, I have just explained about the Swyer syndrome. Now, next, which of these will require evaluation of primary amenorrhea? So this was a multiple answer question. Now, let me tell you what is primary amenorrhea. In a girl, primary amenorrhea in a girl of 13 years of age, or in a girl of 15 years of age. In a girl of 13 years of age, thelarchy, pubarchy, menarche, all absent. Or this usually goes in favor of Turner syndrome or streak gonads or ovarian dysgenesis or gonadal dysgenesis. Okay. Or there is a female at 15 years of age, thelarchy and pubarchy. That means breast development, axillary pubic hair have developed, but there is no menarche. So this usually goes in favor of Mullerian agenesis, or it can go in cryptomenorrhea as well. Okay, cryptomenorrhea as well, because everything is normal, but there is imperforate hymen. Okay, so 13 and 15. So let us see If absence of menses by 15 years of age, yes. So that is primary amenorrhea, correct. No menses within 3 years of thelarchy. That is again, if the thelarchy has started and by 15 she does not get menses, then also that is primary amenorrhea. Now, high TSH with short stature, that is if there is hypothyroidism, short stature. Then again, thyroid hormones are required for development of, normal menstruation. There is a role of thyroid hormones as well. So whenever there is an hyperthyroidism and it is a reproductive age group female, it can lead to abortions. Hypothyroidism, okay, can lead to, amenorrhea. Okay, so this is again coming absence of thelarchy by 13 years of age. So I think all of the above will fit into this answer. Okay. Next, which of the following is seen in HRT? HRT means hormonal replacement therapy. Hormonal replacement therapy, and most common symptom for HRT is vasomotor symptoms like hot flushes, sweating, palpitations. And what is the reason for hot flushes? It is estrogen withdrawal. Okay, so usually questions are being asked on HRT, the symptom, most common symptom, that is hot flushes, vasomotor symptoms, and then they ask about osteoporosis, because estrogen is known to increase the osteoblast activity and decreases osteoclast activity. So when there is estrogen deficiency, there is bone resorption. So she is known to have fractures. Now, in this case, hormonal replacement therapy decreases the risk of breast cancer? No. Is it decrease the risk of endometrial cancer? No. They increase the risk because it is only estrogen that you are giving. Increases the risk of hip fracture or decrease the risk of colon fracture. So the answer to this question is decreases the risk of colon cancer is a wrong answer. Fine. Because here it is increasing, here it is increasing, and here it is decreasing. That will be the correct answer. So here the answer will be decreases the risk of colon cancer. Which of the following is incorrect? Cystocele colposuspension. Cystocele is when there is urinary symptoms because of the bladder neck prolapsing in the vagina. Okay. Then there is uterine prolapse, vaginal hysterectomy, rectocele posterior colporrhaphy, and wall prolapse, sacrospinous colposuspension. So sacrospinal ligament is used, that is vaginal vault suspension is done. That is the treatment of vaginal vault prolapse. Okay, it can be done by laparoscopy. So this is the correct answer. Uterine prolapse or uterovaginal descent, or there is a cervical descent, vaginal hysterectomy is done in elderly females. Surgery for rectocele is posterior colpoperineoplasty. Now, the options given to me by the students is rectocele, posterior colporrhaphy. Actually, for rectocele, that is a rectum prolapsing in the vagina, the name of the correct surgery is posterior colpoperineoplasty. And for the cystocele, the surgery is anterior colporrhaphy. Okay, so this is the correct surgeries. So unless until you give me the correct options, I am not being able to comment upon this question. Okay, so cystocele, the correct surgery is anterior colporrhaphy. For the cervical descent or uterine prolapse, the surgery is vaginal hysterectomy, but we don't do in young females. It is usually elderly females. Elderly means it is 60 plus or 70 plus, or those who have completed their family 45 plus. That is not elderly, actually it comes in the middle age. Okay, so instead of writing elderly, I should write the age. Okay, so it is cervical descent with those females who have completed their family and there is presence of cystocele, rectocele. So we write vaginal hysterectomy with pelvic floor repair. Okay. Rectocele, the correct surgery is posterior colpoperineuraphy, vaginal wall prolapse, sacrospinous, like suspension, where sacrospinous ligament is used to treat the vaginal wall prolapse. So these question, what is the exact options which was given? Only then I will be able to comment. The correct surgeries I have written it here. Now, next question is, a female presented with complaints of dysmenorrhea, dyspareunia on examination, uterus retroverted, tenderness in pouch of Douglas. The obstetrics questions, my colleague and friend, Dr. Anil has already discussed. So I'm discussing the gynae part of this. So do refer to that video as well. Now, female presented with complaints of dysmenorrhea, dyspareunia on examination, uterus is retroverted, tenderness in pouch of Douglas. So this is a very, very clear-cut case, dysmenorrhea, dyspareunia, uterus retroverted, tenderness in pouch of Douglas. It is, the diagnosis is endometriosis, and the gold standard investigation is none other than laparoscopy. So in the previous question, I have explained about this symptoms and I have explained about laparoscopy and I have explained about what are the presentations of 3 type of presentation symptoms like pain, which is congestive dysmenorrhea. The next important symptom is dyspareunia, where it is almost fitting into this question. And third one is infertility. Okay. So here I am going to do a diagnostic laparoscopy. The advantage is I can convert into therapeutic if I find adhesions or if I find I have to treat the chocolate cyst on the laparoscopy. So that is what is an advantage of doing it. So that's all from all those questions which I have been able to collect from my students. That's all. And hope this exam was, you have been able to solve most of the obs gynae questions perfectly.